Yep, we're ready.
Okay, awesome. So thank you everyone for coming to Northwestern Geriatrics Grand Rounds. I am thrilled to introduce Dr. Jennifer Gabbard, and she is an amazing associate professor of medicine at Wake Forest School of Medicine and serves as the director of the Serious Illness and Palliative Medicine Research Program. Her NIH-funded research, and she's a K grant recipient, focuses on the implementation of non-pharmacologic geriatric and palliative care interventions to improve quality of life among older adults with serious illness and those with cognitive impairments, frailty, and advanced cancer. She is a champion of working in collaboration with interdisciplinary health professionals in outpatient primary care to implement evidence-based practices. So please join me in welcoming Dr. Gabbard.
Thank you so much. So I'm excited to have kind of present some of the work. So I'm going to focus on some real world approaches and some insights that we have learned from some pragmatic clinical trials that we have done. So I have no disclosures beyond my funding, which I kind of list at the end of this presentation. So kind of the area that I think about in research is how can we really leverage technology and electronic health record to identify high-risk vulnerable older adults, and then potentially provide personalized care to those individuals without really increasing substantially the workload on busy providers, especially in primary care, by leveraging team-based science. And so really thinking through concepts of like user-centered design, clinical informatics, implementation science, and pragmatic clinical trials. So today I'm going to kind of just briefly go over frailty because I know many of you guys are well versed in this topic. Go over some case examples of pragmatic kind of trials and some lessons that we have learned, and then some next steps and questions that still need to be answered. So, as many of you know, frailty is a clinically identifiable state where they have a diminished physiological reserve, and this predisposes them to increased vulnerability to adverse outcomes. And it's really important to understand a patient's frailty level because then we can really tailor clinical care to their physiological reserve and really move around away from like age-based treatment decisions, which unfortunately has been really the mainstay of medicine for many years. And so even a lot of the guidelines and looking at like screening mammographies and colonoscopies have been so age focused. And so really thinking how can we understand frailty levels to kind of change some of that practices that we've been doing. Also, lots of research has shown that frailty is a risk factor for multiple adverse outcomes. More and more research is showing that it can be a signal for dementia risk even a decade before they clinically manifest symptoms of cognitive impairment. It's also been shown to be a predictor of falls and mortality and other key adverse outcomes. We could have a whole discussion on how do you assess frailty, and there's multiple ways to assess it. But kind of two main models a lot of people think about is kind of that freed frailty phenotype, which is that slow gait speed, low grip strength, low physical activity, fatigue, and unintentional weight loss. And then Rockwell's model is just that like a cumulative deficit model of frailty, and really thinking about kind of patients across the spectrum of either fit or being pre-frail or frail or kind of end stage. And so now I'm going to kind of move on to discuss some pragmatic trials that our team has been involved in. And so the first one we'll kind of look at is a care planning pragmatic study that we did called the Impact Study. And this was funded graciously by the Duke Endowment. And one of the things that we really wanted to focus on was how do we identify patients who need care planning the most? And when we thought about that, we really wanted to focus on those who were 65 and older, who had multimorbidity plus something else. And at the time, there had been research really coming out that if you were older, had multimorbidity plus additional impairments, either cognitive impairments or physical impairments or frailty, you were really predisposed to worse outcomes, having increased healthcare utilization, worse quality of life, increased disability, and increased mortality. And so we really felt that this was a good group to really focus on and making sure we understood kind of what their goals were and making sure we thought through kind of a process for that to be able to integrate it into clinical care. So the next thing we had to think about was how do we do that easily? How do we identify these vulnerable older adults? Many feedback that we got from primary care providers is they did not want to be the ones that have to identify these. And so we wanted to think through a way that we could passively and easily identify these using readily available data within our EMR system. And so next we had to think about how do we pragmatically identify frailty. So in many of these practices, they had, at our institution and other institutions, many have tried to implement, things like grip strength and gait speed, and some have successfully and some have done it, have not been able to really get that integrated and really be able to measure that pragmatically. So luckily at kind of the time, Nick Prodrusky and Kate Callahan were my mentors, and they had been working on taking Craig and all's kind of electronic frailty index out of the UK and kind of build that within the Wake Forest system using readily available data, things like medical diagnoses and laboratory tests and vitals and questions from the annual wellness visit to really get at that kind of Rockwell model of frailty with that cumulative deficit model. And so it's about 54 total deficits. You do need 2 ambulatory visits, and it's about a 2-year look back, but it's a nice way to automatically passively identify frailty, and it scores it kind of on a 0 to 1, with less than or equal to 0.1 is fit versus 0.1 to 0.2 is pretty frail, and those greater than 0.21 is frail. And so once we kind of thought, okay, this will be great, they did some studies showing that the electronic frailty index did predict mortality and falls and other adverse events. We next wanted to think about how do we passively identify physical and cognitive impairments. So we did utilize like ICD-10 codes, but as many of us know, those are vastly underutilized. So at the nice thing is at Wake Forest, they had already rolled out for the Medicare wellness visit a smart form that everyone was supposed to use that had those kind of Medicare questions developed in the smart form as discrete data elements. So the nice thing is it was something we could easily passively pull and develop an algorithm for. So we use questions like if they were positive for their falls risk, if they had impairments in ADLs, and then if they had impairments in cognition based on 2 questions asked during the Medicare wellness visit. So once we kind of thought through, okay, this is how we're going to passively identify these vulnerable older adults, the next question we had is how do we prime these individuals? And part of this even came from my own angst in clinic, was if I even tried to initiate these kind of conversations in clinic, they were very time consuming. A lot of times I was having to do the same thing in the beginning, kind of like, why is it important for us to think through this? Getting them to think through what their goals are and what matters most. And many of them felt like they needed to think more about it. And so I really felt kind of these needed to be primed outside these already really busy visits. And so we really kind of brought in and did qualitative interviews to think through how best to prime. And that got us thinking through this kind of concept of a nurse navigator-led pathway. The nice thing is within our ACO, we already had nurse navigators that were integrated already in these practices that were assigned per risk groups. So they were already embedded, they were already reaching out to patients for patient reminders and other responsibilities. And so we thought, we could kind of train them and how to have these kind of conversations over the telephone and really start priming patients to understand why this is important to think about, thinking about what matters most to them, setting healthcare goals, thinking through who they would want to be their medical decision maker, what was most important to them if their health was to worsen. And we also had the nurse navigators kind of see if they felt patients were more in that pre-contemplative stage, were they in the contemplative stage or oxen phase, and kind of document that. And then they would mail patients a packet that had more information along with kind of a copy of an advanced directive, if they hadn't already completed one, to kind of think through that and bring to their visit. So once we kind of conceptualize how do we passively identify these individuals and then prime them, the next thing is we really felt it was important that they did have this discussion with their primary care provider. So it could really impact clinical care and really impact care plans, but also that their potential loved one or whoever they wanted to be the surrogate decision maker could also be there to really hear that. So it would help them prepare them to potentially make these decisions in the future. And so we had to think about how do we do that? How do we really enable that to happen? And we felt the best way to do that would be during the Medicare wellness visit. The nice thing is that Medicare really wanted advanced care planning to be discussed during Medicare wellness visits. Most of these practices, Medicare wellness visits, were extended visits. Most of them were between 45 minutes to 60 minutes. So it really gave more time for the providers to potentially have these discussions with the patients. They could bring that loved one with them to that visit. And the nice thing too is, there was these advanced care planning billing codes, and any copay is waived if it's done during the Medicare wellness. So there wouldn't be this kind of additional cost that would offset patients to have this discussion during that visit. So we really felt that was kind of the opt-in time to do it. It also would enable it to be something that could be a process over time to kind of occur during once a year during their wellness visit to kind of really have a check-in on where the patients are. Again, like we said, the nice thing is that most of these practices, when we went out, they were double billing already, using Medicare wellness billing codes and often complexity billing. And the nice thing is they could add on additional billing mechanisms with these ACP billing codes to really optimize their RVUs for that visit and really make this a financially sustainable model for providers. And it really, I think, created buy-in for providers also. So next, once we thought through, okay, this is how we're going to passively identify these individuals and prime them and enable them to have this discussion, we wanted to think through how do we then document that? And the key thing I wanted is that we needed to make sure this documentation would be documented centrally so that anyone could find this. Because as many as you know, if a patient comes into the emergency room, that emergency room doctor is not going to go through all the PCP notes and try to read to see if there was ever a discussion. I also felt like we needed to make this easy for the PCPs and also kind of help them know how to have these kind of conversations, because that was also some of the things that we heard from PCPs. So we developed in this thing called the ACP-wise documentation tool. So first, we created a telephone smart form that the nurse navigators would use when they outreach and did these telephone visits with patients. It actually served as a conversational guide. So it was written out how they should ask these questions. We had done prior research about the most common responses that patients had. So we had those as kind of discrete data elements, but we also had free text options. But the other key thing is that we had that the nurse navigator could document that the patient wasn't ready or unsure, or if they didn't have time to discuss. So it really kind of met the patient where they were. We then created a smart form for the providers, and anything that the nurse navigator discussed and documented auto-filled directly into their smart form. So that really enabled PCPs to then build on that conversation that had already occurred. They could see what was documented. They could review that, add on to it if they needed, but then they could then go on to having some more in-depth conversations beyond some of those measures. We then created a smart set, which took whatever they documented in that smart form. So it would embed directly into their progress note, but it also would create a copy as an advanced care planning note directly in the advanced care planning navigator, which is where code status is. So they could just click on code status, see where this discussion was, and then it would add kind of a visit diagnosis and that ACP billing code for them. And again, we really wanted this to be right into their workflow. So you can see this was the Medicare Wellness Smart Form on top. We had the ACP right below that. And everything was kind of structured data elements with optional free text, and they could kind of document if the patient was unsure or not ready to answer. So, once we kind of created that, we did training. We trained all the nurse navigators in respecting choices, along with how to use this documentation tool. We trained the providers on how to use the tool, along with ACP billing codes, as many of them weren't really familiar with ACP billing codes or time requirements, things like that. And then we did some education on prognostication because we realized that also was kind of a gap in a lot of PCPs, and kind of link them on how to use like e-prognosis and those tools to help facilitate that. We created that EHR algorithm to identify eligible participants, and then they were randomized 1-to-1 to either this nurse navigator-led pathway or usual care. And we use something called a Zelen design. And that's where patients were randomized before consent. And then only those who were randomized to the intervention arm are approached for consent. We did that verbally. But even if they refuse to participate, they're still analyzed and intent to treat arm within the intervention arm. And that really allows us to understand kind of real world context for interventions like this. The other thing we really wanted to focus on was having a really large geographic region of these sites to really promote generalizability. So we went across 5 different counties. We had 4 sites that were urban and 4 sites that were rural. We had 8 sites total participate in our intervention. So what were our results? For patients, the mean age was around 77. About 20% were 85 and older. Greater than 80% of our population was frail. About 20 to 25% had physical impairments, and about 20% or more had cognitive impairments. And so we were able to show that by integrating this nurse navigator arm, we're really able to improve advanced care planning documentation and electronic health record, documentation of whoever they wanted to be, that SARI decision maker, uploads of advanced directives into the EMR, uploads and completion of MOLS forms, or some people call those PULSE, wherever you live, and then usage of those ACP billing codes. In addition, we wanted to look at not just documentation, but also, what was the quality of these conversations? And I think one of the things we really found was, these were very high quality conversations. In addition, it really optimized the time of the provider because they were able to really build on whatever the nurse navigator had discussed prior. So the nice thing is, in less than 20%, did they have to go back and discuss what the nurse navigator had to discuss about what matters most and what was most important to them. And they were able to then really focus on building on to that conversation, talking about disease understanding, prognosis if appropriate, unacceptable states, and then, discussion and potentially upload and completion of those forms. The next thing we wanted to really assess was how was the quality of these conversations? Because I think that's also really, really important. And patients rated the quality very high within these discussions with a mean score of 9.56. The great thing is about 80%, so they did go on and talk with their loved ones about their wishes. 64% brought someone with them to that visit, and the majority were satisfied and would recommend the intervention to others. We also wanted to see the providers, how did they feel about using that ACP-wise documentation tool, and did it make it easier for them to have that conversation? And the nice thing is that 71% said, yeah, it made it easier for me to have that conversation. They really felt it was a kind of a nice conversational guide. The majority felt it was easy to use. And the other thing we really wanted is, how did they feel about that nurse navigator priming? Was that something that's needed? And we got that feedback consistently from providers, is that they really felt by having a nurse navigators prime the patients before that visit, it really helped them facilitate a discussion once the patient came in. They were really in that action phase, ready to have that discussion, and they could just build on that discussion. Majority were satisfied, and the majority said if we continued it, they would continue that model within their clinic, which was really great. So what were some lessons learned? And the nice thing of a lot of lessons we learned, it was recently also highlighted in Susan Hickman and all's paper on the care planning umbrella. And it's really that, advanced care planning needs to be an ongoing process. It can't be a single conversation, but it needs to be a continuation. And it needs to evolve based on as patients change in health status and preferences. Also, healthcare utilization is not a good outcome for advanced care planning. And when we're looking at effectiveness, we really need to think about kind of patient-centric outcomes. The other thing that we really found out and highlighted is that patients' readiness really varied. Some were more readily available. Sometimes that changed as a conversation. And so I think it's really important to have things like we did, where the patients weren't ready to discuss at that time or unsure. And then you could build on to that. So maybe in a couple of months, you come back to that conversation and say, hey, have you thought more about that? To really kind of meet the patients where they are, we thought was really, really important, instead of forcing them to try to kind of think through that when they weren't ready. We also really felt that having the PCP involved was really important. Many of these patients trusted their primary care providers. We also had to think about mechanisms that wouldn't increase substantially the workload on these busy PCPs already. So really thinking through that team-based model. The other thing that we really learned, and at this time, a lot of ACP interventions that had been designed had no integration into the EHR. And we really felt that that was really essential to really affect real-time care decisions. Because if it's not readily available for these providers or during admissions, it's likely not going to influence the care that they're going to receive. So next, we kind of started to think about telehealth. And of course, at this time, also COVID was happening. And so we were really thinking, okay, did these need to be in person? Could telehealth kind of play a role? And the nice thing is that at the time, the Impact Laboratory had an RFA for this. So we decided to kind of apply for that, and luckily got funded to see if we could kind of adapt this. So the next thing we had to think about was, how do we pragmatically identify older adults with unrecognized dementia? We had done one of my colleagues had done some follow-up research looking at those Medicare wellness visits. And unfortunately, the sensitivity and specificity of those was pretty poor and really getting at unrecognized dementia. So we knew we needed some other mechanism that was a little bit better. Luckily, Deborah Barnes and her team at UCSF had just been working on kind of the development and validation of eRadar. So we collaborated with her and built that within the Wake Forest electronic health record. And then we did validation testing. And the nice thing is that it really helps predict unrecognized dementia and really gets at the problem that ICD-10 codes, unfortunately, are vastly underutilized in primary care. And so really kind of gets this group that's often missed. So this was a pragmatic prospective single arm pilot study, and it occurred between July 1st of 2021 and May 30th, 2022. And we rolled this out across 7 primary care practices in North Carolina. We designed that EHR algorithm to identify these patients, and then we sent that list to the primary care providers for them to confirm eligibility and capacity. If they felt the patients were appropriate, we utilized their already embedded scheduling team to go ahead and schedule this telehealth visit directly into their clinic workflow. And the visits could either be telephone or video. And then patients could do this in their home setting with hopefully if they had a care partner or loved one could join them. And then we took the feedback that we had gotten from providers to make that ACP WISE tool even better, hopefully. And they use that to kind of guide those conversations and document, and again, make sure it was stored centrally and add in those ACP billing codes for these providers. The other thing we really wanted to focus on is making sure we promoted health equity and really good engagement. So things that we did was we oversampled for minorities with a goal of having at least 20%. And since we were interested in frailty, we utilized that electronic frailty index with a goal of trying to enroll at least 50%. We also wanted to think about socially disadvantaged regions. And so we used the area of deprivation index and tried to enroll at least 20%. And then we did multiple engagement strategies. We met with leadership. We formed a patient and family advisory group who was involved even pre-implementation to implementation and even afterwards. We had site champions at each of the sites and paid them for their time too. We did qualitative interviews. We had all of our materials reviewed by the Maya Angelou Health Equity Group and Impact Stakeholder Engagement, created vision statements and sent those out to everyone and sent out quarterly newsletters. So you can see that the mean age was around 83.5, and a large proportion, greater than 50%, were 85 and older. So this was an older population. We did reach kind of that greater than 20% minority, greater than 50% having frailty, and greater than 20% being from a socially economic disadvantaged region. And then when we looked at kind of care partners, not surprisingly, they were a little bit younger at 71, and majority of them were spouse, not surprisingly. So next we kind of again wanted to look at the quality of these discussions, and we found that 96% of these visits were high quality, and we did not find any significant difference between if they were done by telephone versus video. So, one of the kind of things that we learned and challenges and adaptations is one is anytime you have to build anything inside the EMR, it's very time consuming. So building eRadar into our EMR system, doing validation testing does require significant time, does require significant IT support. So it is something to think about if you do want to think about doing something similar. Also, there's not a great way to pragmatically identify capacity within EMRs. Some EMRs have a button that you can say if they have capacity or not. But as many of us know, that's really problematic unless they're really like an end stage neurocognitive disorder where, capacity will never come back. Because capacity can be fluid. Sometimes you might have capacity to name a surrogate decision maker, but maybe not for really complex decisions like, surgery or something like that. Also, initially, we designed this that it had to be dyad visits with their care partner, and feedback from the Impact Laboratory and our patient and family advisory team recommended not doing that. And we were glad that we didn't, because we did find about 36% did not have a care partner, and we would have excluded a large proportion of our population if we had made that mandatory. The other adaptation we made was initially when we designed this, we were going to make these, it had to be video visits. I was under this preconception that video was going to be superior, and that it needed to be by video. But our health equity advisory team actually recommended we make that optional so that we didn't exclude patients who maybe didn't have the means or ways to do that by video. And I think the good thing is that did really help us with reach, but it did decrease kind of the acceptability among PCPs, because PCPs did kind of prefer it to be done by video. And this did align with prior research showing that patients, with cognitive impairment may kind of exhibit a preference towards telephone visits, maybe due to lack of necessary technology or technology anxiety. So when we looked at kind of reasons, about 39% didn't have internet or smartphone, about 17% weren't comfortable with video, about 25% didn't understand technology, and about 19% preferred telephone. I have seen over time, comfort with video definitely change in older adults. I think more and more are becoming more comfortable with it. But there is kind of strategies that studies have shown that maybe starting the visit with a telephone and then transitioning to video is important. But I think regardless, I think telehealth is still an important thing that needs to continue. And I know right now it's kind of up in the air, and I think it needs to not only just be video, but there is going to be a certain subpopulation that needs to have it by telephone. And so we really need billing mechanisms for both kind of moving forward for our patients. So the next thing we had to think about is, can we scale this? And so one of the things kind of my department head says, like, Jen, nurse navigators are expensive, and not all primary care practices have embedded nurse navigators. And so, is there another way that we can prime patients that maybe is a little bit less intensive, maybe a little bit cheaper before PCP visits? And that made us start thinking about MyChart. And so whenever you think about MyChart and thinking about doing interventions through EMR, you always have to think about do I build it within the existing EMR, or do I build outside the EMR? And so we actually got grants to kind of look at both. So we collaborated with Coda Health and got an STR grant to look at kind of building out. So what we did was we created an EHR phenotype for those 55 and older who had active MyCharts. We sent them a MyChart message that kind of had a hyperlink to the Coda Health, and they had to create an account. And then they kind of did pre and post surveys before going through the Coda Health kind of web-based app that would kind of walk them through this process of care planning. We sent that out to 2,850 participants. And as you can see, we had really low response rates, only about 6.4% of those who were sent a MyChart intervention kind of enrolled. And so, when we did look though at those who went through it, usability was very favorable. We also showed that we were able to improve some of the process outcomes with advanced care planning. But, there was recruitment challenges. And so maybe, not involving the PCP at all really kind of affected engagement. We also felt because they had to actually leave the MyChart, had to hyperlink outside, we felt that contributed to some of the drop off. And so that really had us thinking about really needed to integrate that more into the EHR system. We needed stronger PCP involvement, and we needed to think through multimodal recruitment strategies like adding in telephone outreach, things like that, to really improve participation. And then this kind of led to the work that was funded through my K that I'm currently working on, is really thinking about a user-centered design. So, really co-designing this and first kind of creating a portal-based tool for patients and then doing cognitive interviews. And cognitive interviews looks at, can the patients understand the care planning tool and the questions and the answers? And then usability testing, focusing on, can people use the tool? And then doing feasibility testing, is it feasible to do? So within cognitive interviews, we took what the nurse navigators did over the telephone and then built that as kind of a portal-based tool. We got expert consultants to kind of help us with that process. And then we did these cognitive interviews with patients and their care partners and asked them to come in and see if they could really understand, looked at comprehension, judgment, response, and retrieval, and content validity. And we did 2 rounds of these cognitive interviews to kind of finalize our tool. Once we did that, we then moved on to usability testing using something called a Think Out Loud protocol, where both the patients and the care partners came and used the tool. And we did 3 rounds of usability testing. Again, we really wanted to focus on kind of that health equity standpoint and had a large, greater than 40% from a racially economic minoritized group in our intervention. And we're able to show that after 3 rounds, we were able to have really excellent usability of our tool. So now we're kind of looking at feasibility testing. And so we've, developed that EHR algorithm to identify patients. The PCPs kind of confirm eligibility. And then they receive a MyChart message that comes from their PCP to really promote that trust that they have with their PCP. It adds in a motivational message, and then the tool is directly attached to that for them to complete. If they don't respond, they get a reminder message with a different motivating message. And then if they don't, that's when we add kind of that telephone outreach. And then we reach out to patients by telephone, see if, what the issues were, and if they would be interested in completing it by telephone or for us to resend it to them. And then we created that smart form for the PCP. So whatever the patients filled out through MyChart would auto-fill into that smart form. So then the PCPs just have to review that and build onto that conversation. Again, we have that smart set that then embeds all those answers right into their notes, creates a centralized documentation of that, adds that ACP billing code. And then the nice thing is we already rolled out a quality metric that everyone 65 and older should have a goals of care conversation once a year. And we created this smart set to then, meet that quality metric for these PCPs. So what are some future directions? So next, we're right now we're still in that feasibility, but we're showing really good feasibility, about 83% completion rate. So we're wanting next to move on to kind of a randomized controlled trial. So the questions always right now in this field is, what is the best primary and secondary outcome measures? And how important is it that these measures be pragmatic? And how do you define that? I worked with some colleagues, Laura Hansen and Carpenter and others, really thinking through pragmatic outcomes as a kind of a spectrum. And there's certain core features and ideal features, and not all of them maybe need to meet those hallmark features that they're completely embedded in. So I think we need to really think about pragmatism across the spectrum when we think about outcome measures. Next, I really love this one by Tay Kim, and thinking about kind of the different frailty scores and levels and what do we need to think about. And in all of them, patient-centered goals is crucial. So our team now is kind of thinking about, how do we tailor care planning based on this stage of frailty to really improve clinical decision-making and quality of life? how best to pragmatically involve care partners is still kind of a question we're still grappling with. So love any advice there. What is the best way to scale this that also allows for site-specific adaptations? So really thinking through what are those core features versus forms. And the other thing is, what is the best wording to use when we describe frailty to patients and care partners, is some of the things we're interested in. We also have done some work looking at frailty and social vulnerability. And this was a study where we looked at kind of the EFI and area deprivation index and really showed that, the combination of frailty plus living in an area of economic disadvantage further increases your risk of healthcare utilization beyond individual risk. So that made us kind of think through, can we use then the electronic frailty index and the area deprivation index to identify these high risk individuals, then screen them for social determinants of health, and then link them to resources that they need. And the results of this pragmatic clinical trial will be presented at AGS. So I hope you guys come and see our oral presentation. So the other thing we wanted to think about is, Kate Callahan and Nick Podjuski had looked at the EFI and being predictive of risk outcomes in primary care. And so a group of us started to think about, well, what about in older adults with cancer? And we did show that it was predictive of survival and overall mortality. And so now our team is kind of thinking through, how do we then tailor geriatric oncology care to frail older adults? What are some modifiable risk factors in this group to improve quality, preserve function, and improve survival? And then what is really this association between pain and frailty in older adults? And is that a potentially modifiable risk factor? Is some of the work our team is currently working on and thinking about. So key takeaways, I think frailty screening can really help us differentiate between biological and chronological aging. It can really help us improve risk stratification and care planning. Pragmatic clinical trials can really help us inform real world implementation and what is truly scalable and is going to work in real world. And I think we have to, move beyond just identification of if someone's frail, but really thinking about how do we assess interventions that can maybe mitigate decline, and then really integrating their frailty status into clinical decision making. So thank you, everyone. I will take questions now. And of course, I couldn't do this without my amazing research team and funders.
That was a fantastic talk, Dr. Gabbard. Like, way to go. Yay. So we'll open it up to questions. And I'm sure there's a few in our group. Well, I have one. For the randomized consent trials, was that hard to get it pushed through your IRB?
Yeah, the nice thing is that we really were able to show that this is supposed to be part of usual care. And so that we were really just kind of enhancing a usual care model. And so because of that, we were able to get that through pretty well to do a waiver of consent for most of these interventions. Like I said, the impact study, we did a little bit different. We did consent those who were randomized to the intervention arm. We did verbal consent, but we didn't consent the control arm at all. So it was only the intervention arm that you approach for consent. And then even if they don't consent, you still analyze them in the intervention arm as an intent to treat. So that can be good and bad, because if you have low engagement in your intervention, then you have a lot of people who never went through your intervention, and it's going to be hard to show a difference between. And then of course it depends how good your usual care arm is. Luckily, usual care is very poor, and so it wasn't that hard to be able to show a significant difference in something like this. But for the tele one, we did do a full waiver of consent. The nice thing is, telehealth during COVID started to had the expansion, was already being part. So our IRB was pretty good about that. And we use Avera, kind of our central IRB. And we did have to have a couple back and forth, because central IRBs are kind of used to more pharmaceutical clinical trials. And so sometimes they don't really understand non-pharmacological interventions. And so we did have to do some back and forth for them to kind of, because they wanted like really kind of complex language and things like that we had to really go back and forth. But so it does take a little bit of leg room, but I have some really good language. So if anyone wants to do that, you can steal some of my IRB language for that. So
I might take you up on that because it's
yeah.
always a struggle with the IRB.
Yes.
Any other questions?
No question. I just wanted to say thank you for this awesome talk. And I love that this is your research interest, and it's like inspiring because it's such a nice, I don't know, having these important conversations is such a great part of what we do. And I love that you've kind of done this work in this field. So thank you.
Thank you so much.
Yeah, that was Dr. Alex Petrakos. She runs our home care program. So a lot of people end up going into home care as they get more frail, and then ultimately heading towards hospice and goals of care. And she is all over what matters most. So that's kind of her
nice.
research interest. Yeah, what matters
Yes.
most is huge, you know.
Yeah. Are you doing a lot with the age-friendly kind of initiative then?
Yeah, I did that. I did a lot of that during my training, and it just resonates really nicely, I think, with all of us as geriatricians too. So it's fun to see that you've done so much work in this area.
Oh, good. Well, definitely let me know. We're obviously with all the new CMS kind of age friendly. We're trying to roll this out now because we're part of Atrium and Advocate and Aurora. We're rolling this out across this gigantic healthcare system. So any words of advice, send it my way.
Well, if only I had advice.
Now, I think we're having similar experiences here because we're rolling out and we're buying more hospitals around us and health systems. And so our home care program is being tasked to go all the way up to Wisconsin border and then all the way over to the Indiana border and then out about 2 hours west. And Alex can only get to so many places in a day. So it's
So we have similar pain. So maybe we'll have to think about that together. Because now ours is same thing, Wisconsin, Illinois, Tennessee, North Carolina, Georgia. Yeah, so very large.
it's like we need more geriatricians just stamped and, you know, to truly drink the water or the Kool-Aid of, you know, what is the right thing to do for our patients. Well, thank you so much for a fantastic grand rounds. It was
thank you.
just truly enlightening to hear everything that you're doing. And so please join me, lots of claps and hopefully some future collaborations. Thank you so much, Jennifer.
Thank you guys. Okay, take care.